Hello, my name is Jane Coe, and I'm a chest radiologist at NYU Langone Health. I'd like to thank Chess for inviting me to participate and present this discussion on radiology and bronchiectasis and nontuberculous mycobacteria, and this is part one of a series of discussions. First, my disclosures, and on to our objectives, which are to review high-resolution CT anatomy, and we'll cover imaging of bronchiectasis. We'll discuss some HRCT presentations of nontuberculous mycobacteria, and hopefully this will be useful in clinical practice. So let's first begin with definitions in HRCT anatomy. An understanding of lung anatomy is essential for interpreting HRCT for ILD. The secondary pulmonary lobule is the smallest lung unit that's marginated by connective tissue. It's an approximately 1 by 2 centimeter polyhedral structure. It's composed of a number of acini, typically about 12, but can vary in number. The lobule is marginated by interlobular septi that are composed of connective tissue and contains pulmonary veins, lymphatics, and interstitial fluid. The lobule centrally has a lobular artery and accompanying bronchiole, and these branch within the secondary pulmonary lobule. The interlobular septi are only about 0.1 millimeters in thickness, and therefore it's not surprising, given the resolution of high-resolution CT that can resolve 0.5 to 0.3 millimeter structures, that we typically do not see the secondary pulmonary lobule and the interlobular septi. We can estimate where the lobule is, such as in the periphery of the lung, where we see a lobular artery and a bronchus that enter into the periphery of the lung. And typically we do not see pulmonary arteries within 5 millimeters of the periphery of the lung and bronchi within 1 centimeter of the lung periphery. So therefore, bronchiectasis can be indicated when we do see bronchi within 1 centimeter of the pleura. It's termed and defined by the Preissner glossary of terms as irreversible dilatation of bronchi. The bronchi are larger than the accompanying pulmonary arteries. They fail to taper. The term dilatation tends to be used when the enlargement is of unclear chronicity, and we oftentimes look for accompanying signs of airway inflammation or infection, which is manifested by thickening and or mucoid impaction on CT imaging. And here are 3 terms we utilize when we describe bronchiectasis: cylindrical when the dilatation is tubular, varicose when the outer contour is beaded, cystic when the abnormalities are round. And here we can see the thickening of the bronchi. The bronchi, or this bronchus in particular, dilated and seen well within 1 centimeter of the periphery of the lung. The signet ring sign is an indicator of bronchiectasis, and here we see the dilated bronchus, which represents the ring or the band, and the pulmonary artery, which is the disc of the signet ring. Bronchial enlargement can well be transient, and here's an example of a patient with COVID-19, and there is diffuse ground glass opacity representing pneumonitis. The enlargement is indicated by the caliber being larger than the accompanying pulmonary artery, and on follow-up we can see how the size of the bronchus has decreased and is smaller than the accompanying pulmonary artery, in addition to the resolution or near resolution of the ground glass opacities with faint amount remaining. The small airways are termed the bronchioles, and typically are non-cartilaginous airways that are less than 2 millimeters in size and are composed of terminal and respiratory bronchioles. The respiratory bronchioles are distal to the terminal bronchioles and give rise to alveolar ducts and do have some gas exchange. And we use the term bronchiolitis to imply disease at the small airway level. Central lobular nodules and air trapping are indicators of small airways disease. So let's discuss air trapping, which is a sign of small airways disease and appears as heterogeneous lung, also termed mosaic attenuation. And this pattern can be formed by air trapping, which creates mosaic perfusion along with vascular occlusive processes, or ground glass opacity. So when we see a patchwork of different attenuations that are geographic, that conform to what we would expect to be confluent secondary pulmonary lobules, we first look at the darker areas of the lung and look to see whether there are smaller number of vessels and smaller caliber vessels. And here we can see how the vessels are smaller in number and caliber as opposed to the higher attenuation lung. And therefore, we can ascertain that there is mosaic perfusion from air trapping, and notice how there is bronchiectasis and clustered nodules indicating airways disease. There can be a combination of ground glass opacity and mosaic perfusion, as in this case, and we look for a 3-density sign, which relates to the presence of both these two entities. So we have determined that there is mosaic perfusion, and there are areas of higher attenuation that are more dense than normal lung. So there are 3 densities. The first is air trapping, the second more normal lung, and the third is the ground glass areas. And notice how there's inward bowing of the trachea, indicating that the patient may not be in full inspiration, and therefore this accentuates the air trapping. And these are the nodules and bronchi as mentioned. Bronchiectasis may not be the primary pathology, but the secondary, and this we oftentimes see related to fibrosis, and in this case, radiation fibrosis, see how the bronchiectasis is really confined to the area of consolidation. And of course, when there is diffuse lung disease, the bronchiectasis is secondary to the reticular fibrotic process. Some helpful features to evaluate with interstitial lung disease and airways disease is whether the process is diffuse versus multifocal, unilateral versus bilateral, affects the upper as opposed to lower regions or anterior posterior, and we look to see if the process involves the central and the peripheral regions or both. Additional features that help differentiate interstitial lung disease and airways disease is to look for reticular opacities to assess lung volumes. Oftentimes, airways disease processes lead to hyperinflation, whether there's a pectus excavatum, esophageal dilatation, and hiatal hernia, trachea, and pancreas. So we'll touch on some of these in the ensuing discussions. So let's move on to the CT presentations of nontuberculous mycobacteria. There are 4 differing presentations. The first, the nodular bronchiectasis presentation, fibrocavitary and disseminated disease, and hypersensitivity pneumonitis. Hyperinflation in this example of a patient with nodular bronchiectasis, NTM, is indicated by the larger lung volumes, and we use the 10th posterior rib as a general guideline, and typically this intersects the dome of the diaphragm at midline, and here you can see it's the 12th rib that intersects, so this suggests hyperinflation, and we can see the flattening of the diaphragms on the lateral radiograph. And there are small pulmonary nodules that correlate with small centrilobular nodules that are indicative of small airways disease. Central alveolar nodules can be separated into tree and bud opacities and diffuse ground glass nodules. Both of these nodular patterns are represented by evenly distributed nodules within the secondary pulmonary lobule, although the tree and bud nodules tend to be more patchy, they're solid in attenuation, and they indicate infectious bronchiolitis typically. The diffuse ground glass nodules are more ill-defined and more homogeneously distributed and indicate bronchiolar and peribronchial disease that is seen in respiratory bronchiolitis and hypersensitivity pneumonitis. Here's an example of tree and bud opacities with small solid nodules that are clustered, and we can better see this on maximum intensity projection imaging, which is the method to view thin section data in thicker sections and display the brighter voxel. We can see the relationship of the nodules by far better. And here is a close-up of the clustered solid central lobular tree and bud nodules in a patient with NTM. Now, right middle lobe and lingular predisposition has been described with NTM, and here we can see the signet ring sign, the dilated bronchi, particularly in the middle lobe and lingula. The disease is progressive overall, and there can be multiple findings that do wax and wane over short intervals. And here is an example of an individual with tree and bud nodules that subsequently 6 years later developed more confluent opacities in addition to new tree and bud nodules, such as in this area in the lingula. And imaging is best performed with less than 1.5 millimeter sections to ensure spatial resolution. And here is 8 years later, we can see how the process has progressed with more confluent consolidation within both of these lobes. Scoliosis is associated with NTM, and here we can see on the coronal imaging nicely the scoliosis, and there are tree and bud nodules in this individual in addition to mosaic perfusion related to air trapping. Here's an example of lung hyperinflation, and we can see multiple nodular opacities with confluence, particularly anteriorly in the middle lobe and lingular regions. There's nodular areas in addition more superiorly. And notice the pectus excavatum, which is what we have been seeing with patients with nontuberculous mycobacteria. Notice how the ribs are pretty aligned, suggesting that the patient is not rotated, and it would be difficult to call pectus in a patient that is rotated on a radiograph. This is the correlative on CT, and we can see how the sternum is depressed, and here consolidation with nodular opacities. Hiatal hernia is something we also evaluate for, as aspiration has been associated with NTM. And this patient had achalasia and had severe aspiration and was infected with M. coloniae. And here we can see the sign that there may well be a dilated esophagus. This is the azigoesophageal recess that is displaced by a very large distended esophagus that is filled with intraluminal esophageal contents. The azigoesophageal recess is typically concave to the lung and is usually more at midline. Fibrocavitary nontuberculous mycobacteria presents with large cavities, and this patient had a colonic interposition, which is typically not performed anymore, but there are these thick-walled cavitary areas and dense consolidation. On CT, we can see how there are large areas of destruction, severe consolidation, and notice the elliptical shape of this finding, which indicates potentially a pleural process. And notice also how the lung is displaced. This is a thick-walled chronic pneumothorax related to communication with the diseased lung, and this was a bronchopleural fistula. And notice the multiple nodules and confluent areas. And nontuberculous mycobacteria can mimic TB on imaging given this fibrocavitary presentation. Nontuberculous mycobacteria can complicate silicosis, and silicosis is characterized also by centrilobular nodules due to the lymphatics running in the centrilobular region. There oftentimes are calcified nodes with eggshell calcification, and notice how this patient had this large dominant lesion that actually 2 years later became cavitary, and this was nontuberculous mycobacteria that was superimposed on silicotic lung disease, so complication of silicosis. Here's another case of cavitary nontuberculous mycobacteria. This thick-walled, air-containing structure represents nontuberculous mycobacteria, probably due to emphysema that will predispose to superinfection. And we can see how this individual also had fibrotic lung disease related probably to smoking-related interstitial fibrosis. Notice how the cysts are relatively larger in size than typical and are separated from the periphery of the lung in some areas, suggesting this may be SRIF rather than usual interstitial pneumonia. Nontuberculous mycobacteria can present in a disseminated fashion, and this individual was a young patient with a large heart or cardiac silhouette, and we can see how the higher and right paratracheal regions are large, and this was an opacity that probably was in the lung. We can see how the AP window interface with the lung is preserved. And here we can see the abnormality in the left upper lobe, the large paratracheal region, and hyoadenopathy, and the enlargement of the heart was related to pericardial effusion, all in this individual with disseminated nontuberculous mycobacteria. Immune reconstitution inflammatory syndrome, or IRIS, has been described in patients with nontuberculous mycobacteria in addition to tuberculosis. This can occur also after discontinuation of anti-tumor necrosis factor agents and is on the order of case reports. And typically, patients develop this after being placed on heart, and the nontuberculous mycobacteria has not had a chance to be fully treated. Here is an individual who had enlargement of the right paratracheal stripe. It's greater than 3 millimeters, and there is convexity in the AP window region related to adenopathy. The patient 1 month later, after being started on heart, developed the bulky adenopathy in the hyoid region. There's widening of the SVC contour. There is persistent thickening of the right paratracheal stripe. And this is all suggestive of immune reconstitution. And this was a CT scan showing the adenopathy that dramatically increased. Here's a different case in which the adenopathy increased from this size on presentation to a much more bulkier size, and the left upper lobe abnormality also increased and became very much more mass-like. So the last presentation is hot tub pneumonitis, in which there are multiple centrilobular ground glass nodules, as is seen with hypersensitivity pneumonitis. And notice how the ground glass nodules fail to touch the periphery of the lung. They evenly distributed throughout the secondary pulmonary lobule, and in this case, the lung. And this patient had frequent sauna use and was diagnosed with nontuberculous mycobacteria and hypersensitivity pneumonitis. So in conclusion, bronchiectasis is accompanied by other signs of airways disease, and we look for tree and bud nodules, lung hyperinflation, and air trapping. And there are 4 presentations of nontuberculous mycobacteria that we keep in mind, and hopefully this will be useful in diagnosing individuals with nontuberculous mycobacteria. This is part 2 of a series of discussions on radiology and bronchiectasis and nontuberculous mycobacteria. Again, I'd like to thank Chess for inviting me to participate. First, my disclosures, and onto our objectives, which are to review the broader differential diagnosis for bronchiectasis, focusing on those entities that are diffuse or multifocal, and we'll discuss some features that can help us narrow differential diagnoses when encountering individuals with bronchiectasis. So we talked about definitions and HRCT anatomy and some of the presentations of nontuberculous mycobacteria, and for this portion of our discussions, we'll focus on the etiologies for bronchiectasis other than NTM. When we encounter what we think is bronchiectasis, we need to keep in the back of our mind whether, rather than bronchiectasis, we may be dealing with emphysema that's surrounded by inflammation, fibrotic lung disease, or cystic lung disease. In terms of those entities that we really think are airways disease related, there are a large proportion of cases that are indistinguishable on CT imaging, and there are a large number of causes of bronchiectasis. And we'll try and present an approach that may help narrow the differential diagnosis. So when we encounter airways disease and bronchiectasis, we can first consider if the disease involves one lobe or is relatively unifocal or multifocal or diffuse. When unifocal or involving one lobe, we think of infections such as tuberculosis or colonization by allergic bronchopulmonary aspergillosis. There are congenital etiologies, foreign bodies, hematomas and carcinoids, broncholitis, and strictures. So here's an example of a dilated bronchus that's completely mucoid impacted, and there's a rounded area in the more proximal aspect, and there is always concern that there is an endobronchial lesion that's leading to chronic mucoid impaction. On off-coronal imaging, we can by far better see how the lesion forms acute angles with the air column of the right lower lobe bronchi. And this indeed is an endobronchial carcinoid that led to mucoid impaction. The acute angles indicate an endobronchial location as opposed to more obtuse angles in which a lesion is compressing the airways from outside. This individual had undergone PET-CT, and carcinoid lesions, particularly typical carcinoids, tend to have lower metabolic activity on FDG PET. And this was confirmed surgically, this proximal aspect with mild uptake to carcinoid, the less avid or non-avid areas mucoid impaction. Focal bronchiectasis, or one location of bronchiectasis, can be seen with congenital abnormalities, such as in this individual with bronchial atresia. We can see this geographic low attenuation area on inspiratory CT, and this focally dilated bronchus with distal mucoid impaction. This bronchus could not be connected with the central airways, and the low attenuation areas represent mosaic perfusion from air trapping, and notice the small number of vessels and the small caliber of the vessels. And this was accentuated on expiratory imaging, in which the dark areas failed to increase in attenuation a large degree, and the more normal lung anteriorly and then the contralateral side increased in attenuation as expected. And this just is an iodine image from a dual energy perfusion map, just showing the decreased iodine delivery due to the air trapping. So let's move on to multifocal and diffuse bronchiectasis, and there are some zonal predispositions that may be helpful for differentiating etiologies. The first is central and mid-lung predominance in relation to the hyla, so more centrally as opposed to peripheral. And we think of allergic bronchopulmonary aspergillosis, congenital abnormalities, and tracheobronchomegaly. Let's take a look at allergic bronchopulmonary aspergillosis. We typically think of the finger and glove sign, in which there's large central mucoid impaction within dilated bronchiectatic airways. And this patient had both aspergillus and nontuberculous mycobacteria within this region. A characteristic of allergic bronchopulmonary aspergillus is the presence of high attenuation mucus. And you can see here on typical soft tissue or mediastinal window settings, we can see this mildly high attenuation area corresponding to metallic densities or components that are concentrated by the aspergillus. And this is enhanced by narrow windowing. This narrow windowing brings out this brighter attenuation, and it's been shown to suggest allergic bronchopulmonary aspergillus. Here is another example of dilated, more central bronchiectasis with an endoluminal opacity representing aspergillus and ABPA. So let's discuss the upper to mid-lung predominance in craniocaudal dimension. The cystic fibrosis and tuberculosis and classic NTM is what we typically think of. And here is an example of cystic fibrosis, just showing the upper to mid-lung predominance. Notice the severity of the bronchiectasis with varicose bronchiectatic areas, bronchial wall thickening, and more confluent airspace opacities. And this is on a 2 millimeter coronal multiplanar reformat, and minimum intensity projection imaging can aid us in visualizing the low attenuation areas of air trapping. Other clues in terms of cystic fibrosis include an atrophic fatty replaced pancreas, And there is adenopathy related to the chronic inflammatory state. And notice the prominent bronchial arteries arising from the proximal descending thoracic aorta. And this is due to the chronic inflammation that recruits these vessels. In terms of anterior lung predominance, this is in the lower lung, and this is the nodular bronchiectatic presentation of NTM that we touched upon. And here is another example, anterior middle lobe and lingula, mucoid impaction, bronchial wall thickening, and dilatation, as seen on axial image and also anteriorly on the sagittal plane. So in terms of posterior predominance, so we think of tuberculosis and nontuberculous mycobacteria in the classic presentation, typically in the upper lobes, and aspiration in the lower lobes when posterior. Here is the patient with active tuberculosis, and we can see the calcified granuloma indicating latent TB, and we can see this mass-like area with cavitation, larger nodules, bronchiectasis, all consistent with active tuberculosis. Here is an individual with aspiration pneumonia, and we can see the consolidation, the wall thickening that's moderate to severe, and the mucoid impaction in more distal airways. And notice how the anterior lungs are relatively spared. In terms of differentiating patients that have bronchiectasis with and without NTM infection, those patients with NTM, not surprisingly, predominantly had more right middle lobe abnormalities. There was less bronchial wall thickening in the lower lobes. There was less bronchial dilatation also in the right lower lobe, and not surprisingly, thicker and larger cavities. And there was less ground glass opacity, something we typically do not see with NTM. As we think about bronchiectasis, there are a number of entities, particularly autoimmune, that overlap in terms of appearance and can present with diffuse bronchiectasis. Inflammatory bowel disease can be affected by bronchiectasis, and pulmonary disease is seen in 0.2 to 0.4% of patients with inflammatory bowel disease, and it's typically the bronchiectasis presentation. Tracheobronchitis can occur, and the pleura can also be affected very rarely, and organizing pneumonia and fibrosis have been reported. And here is severe mucoid impaction, bronchiectasis in this patient with ulcerative colitis. There are additional findings we can look for. We touched upon the pancreatic atrophy with cystic fibrosis, the pectus excavatum and scoliosis with nodular bronchiectasis, presentations of NTM, hiatal hernia with NTM and aspiration, and high attenuation mucus and or endobronchial filling defects such as with ABPA, and calcification and bronchiolith carcinoids and hematomas. And of course, foreign bodies can be radiodense. Situs inversus totalis is described in primary ciliary dyskinesia, but is not seen in all cases. A large airway may bring up the diagnosis of tracheobronchomegaly. There's expiratory central airway collapse, which can lead to recurrent bronchiectasis, and small lungs and pulmonary arteries may indicate an infection at an early age, and ablative bronchiolitis, termed Swire-James. Here's an example of a foreign body. We can see how it's dense, and there's a large amount of inflammation within the airway and pneumonia distal to the radiodense foreign body. And this is seen on the coronal image to lie within the right lower lobe airway. Here's an example of situs inversus totalis, just an example, just emphasizing how we should pay attention to the marker as radiologists. Notice how the heart's on the right side, the liver on the left side, and there is central-lobular nodular opacities, particularly in the right side of the patient and also on the left, consistent with infectious bronchiolitis. Here's an example of tracheobronchomegaly. Notice how the trachea is large, but it also has an undulating contour, and there are these sacculations. And notice how the bronchi are large also, in addition to the trachea, and this predisposes to recurrent infections. And here you can see a patient with a CT scan, and then 4 years later, the recurrent pneumonias that this individual had with mucoid impaction, bronchiectasis, and consolidation both lower lobes. Here is an example of tracheomalacia and excessive dynamic airway collapse, two forms of expiratory central airway collapse. Tracheomalacia can accompany bronchomalacia, and the tracheal cartilage is thickened and abnormal and oftentimes distorted, and helps differentiate from excessive dynamic airway collapse, in which the anterior cartilage is relatively normal appearing, but the posterior membrane invaginates anteriorly to a greater degree during active exhalation on dynamic expiratory maneuvers. And so these two are forms of expiratory central airway collapse that can lead to recurrent infections. So in conclusion, an approach to bronchiectasis includes evaluation of distribution, both in terms of central, peripheral, and upper-lower distribution. And this can help us potentially narrow down the differential diagnosis, and attention to ancillary findings such as the trachea, chest wall, and mediastinum may also be helpful in identifying the etiology. So with that, this concludes part 2 of our discussion. This is part 3 of a discussion on radiology and bronchiectasis and nontuberculous mycobacteria. My name is Jane Coe. I'm a professor of radiology at NYU Langone Health, and it's really great to be here to continue our discussion on this topic. First, my disclosures, and on to our objectives. For this portion, they are to review some challenges that we can encounter when imaging patients under evaluation for bronchiectasis. And these are the topics we've covered previously, definitions and HRCT anatomy that are pertinent to bronchiectasis imaging. We covered the many presentations of nontuberculous mycobacteria and how to try and differentiate some of the etiologies for bronchiectasis. And we'll cover some challenging scenarios. So there is a broad differential diagnosis when we first encounter what appears to be cystic appearing findings: emphysema, bronchiectasis, pulmonary fibrosis with honeycombing, and cavitary or cystic lung disease can all overlap and also coexist within the same patient. Emphysema tends to be upper lobe, and we typically think of paraseptal emphysema. Bronchiectasis more centrally, pulmonary fibrosis with honeycombing with more accompanying reticulation ground glass, and cavitary and cystic disease as isolated lesions. So how can we differentiate these findings? Well, distribution is something we touch upon, and it's useful, and we'll go through some examples. Bronchiectasis in less affected areas of the lung is an indicator that we may well be dealing with primary airways disease, and we can look for air trapping and bronchial wall thickening, other indicators of airway disease, in addition to evaluation of consolidation, ground glass, and reticulation, and assessing the degree of these relative to the bronchiectasis. It's very helpful to scrutinize less severely affected areas, as end-stage severe lung disease oftentimes has overlapping appearances. So let's begin with fibrotic lung disease, and there's oftentimes reticulation present in ground glass, and there's a large amount of architectural distortion that oftentimes is more peripheral. And this is greater than the degree of bronchiectasis that we see in the central areas of the lung. And here is the peripheral bronchiolectasis. That's traction. And we can see honeycombing because of the stacked cystic areas. And in this lung, we can see how there's maybe some normal lung. So this is severe traction bronchiolectasis. And this is to a greater degree than any abnormality seen in more normal appearing lungs and more centrally in terms of bronchiectasis. So this indicates perhaps fibrotic disease is the primary etiology. And this is secondary traction bronchiectasis and bronchiolectasis. Also, shallow and stored lung volumes is also often present in fibrotic lung disease. And this is a case of patient with fibrotic hypersensitive pneumonitis, and see the varicose and slightly cystic bronchiectasis all confined to the area of consolidation. So this is secondary traction bronchiectasis. Now, this case is encountered oftentimes when individuals show up acutely ill, and this patient lacked any prior imaging. Notice how there's large cystic abnormalities that we need to consider whether this is truly cystic disease or is this emphysema that's surrounded by abnormality. And here you can see there is a good amount of consolidation, so it should bring up the fact that perhaps this could be emphysema that's surrounded by inflammation that makes the walls of the emphysema seem much more perceptible. So a clue is to look at more normal areas of the lung. We see indeed this patient does have central lobular emphysema. These are imperceptible walls, holes that appear to be punched out of the lung. And this patient did not have any prior studies, but was suspected to have bullae and emphysema given the degree of consolidation that could have thicker walls due to the inflammation. This patient was followed up, and notice how everything cleared and the walls became imperceptible, consistent with what we typically think of as central lobular severe emphysema with bulla, in addition to some periseptal emphysema. So a pitfall when patients have underlying emphysema. And comparison with old films, of course, is most helpful, but if there is no old films, a short-term follow-up can help elucidate as needed. So in this case, we can wonder if there is bronchiectasis or honeycombing, and there are some clues. Notice how there's a large amount of cystic abnormality, predominantly in the middle lobe and lingula. And there are a number of large cystic abnormalities that seem to radiate from central to peripheral, indicating that this may well be bronchiectasis. There are also low attenuation areas of air trapping, mosaic perfusion with decreased vessel caliber and number, and probably related to air trapping. And we can scrutinize the less affected areas. And here in the lingula, we can see the varicose bronchiectasis that is elongated and characteristic of bronchiectasis. So this is rather severe middle lobe and lingular bronchiectasis rather than exuberant honeycombing, in which there is more of a peripheral predisposition. This is cystic and cavitary disease. That's the primary etiology. And this is a case of lymphocytic interstitial pneumonia, which can occur in both men and women, and is oftentimes secondary or seen in the setting of autoimmune disease, particularly Sjogren's patients, but also rheumatoid arthritis. And of course, there are overlap patients. And there's a polyclonal lymphocytic and plasma cell infiltrate that create the cystic areas, perhaps through air block phenomena. And these cases of cysts can be accompanied by ground glass opacity, central lobular subpleural nodules, and there may not well be cysts even in LIP. And the differential diagnosis is light chain deposition disease and amyloid. And notice how these cysts are peribronchiovascular in distribution, so therefore are in the similar location as to bronchiectasis, but note how the walls are much thinner than is typically expected that with severe bronchiectasis. Now, this is another case in which we can question if this is primarily bronchiectasis or is this fibrotic lung disease. Notice how in the less affected areas, there clearly is a reticular process. It's subpleural, it's peripheral in distribution. And then there are these numerous cystic areas that could appear to be bronchiectatic, but this is something that we've seen in patients with connective tissue-related ILD, exuberant honeycombing that actually exceeds the degree of reticulation and ground glass that we typically observe in patients with pulmonary fibrosis. So this is the exuberant honeycombing sign seen in patients with connective tissue-related ILD. Campbell syndrome can lead to asymmetric bronchiectasis due to bronchial cartilage deficiency of the 4th through 6th order bronchi. And therefore, the abnormalities of bronchiectasis can appear very cystic. Notice how the central airways are not as dilated. There's no bronchiectasis. There are signs of airway infection with central lobular nodules and bronchial wall thickening. And we can see here dilated varicose bronchiectasis as an indicator that this may well indeed be bronchiectasis. When following individuals with nontuberculous mycobacteria, there are a number of nodules that can wax and wane in size, and anything that is slowly progressive may represent infection, but the other differential diagnosis is neoplasm. And this is a lucency that actually was surrounded by some ill-defined ground glass and ultimately became more soft tissue and nodular. And this is a sign that there may well be potentially neoplasm, which this was confirmed to be. Here is a colored case in which we see sizable nodule in the left lower lobe that has worrisome appearance with the ground glass. This indeed was followed up and shown to decrease, whereas another finding increased. This is the waxing and waning findings of nontuberculous mycobacteria. And this new or increasing solid nodule was actually followed up and confirmed to decrease and was nontuberculous mycobacteria. So just exemplifying the challenge of imaging in patients with these diseases. So future directions, we're not touching much about quantification of bronchiectasis, but just to mention that grading is challenging in terms of the severity and the degree of lung affected. And this is something that deep learning tools may aid us in assessing patients and quantifying their disease in bronchiectasis. So in conclusion, emphysema, bronchiectasis, and fibrotic lung disease can look similar, particularly when severe, and be both cavitary and cystic in appearance. Comparing with prior imaging and identifying any additional CT findings that can clue us into the diagnosis of bronchiectasis is very useful, and for also monitoring diseases in patients with bronchiectasis, such as nontuberculous mycobacteria. So with that, I thank you for your attention.